You all can come on, be seated. You all be seated. All right, well, good morning to each of you. We are so glad that you are here today. For those who are in the sanctuary, those who are viewing, we appreciate you hearing the clarion call and making it your business to be present with us today. We want to thank healcollaborative and Attendees for being here. Thank God for those who have traveled from Georgia and from Boston and from other areas who have come here today for this much needed education. So I know many of you are saying, why am I here? Why is it so important for me to be present today? Brothers and sisters, kidney disease is a major issue in our community. We in the Black community, we suffer from this in disproportionate numbers, and it is so critical that we receive this education and we are informed on ways that we can take care of ourselves and know the resources that are out there and that are available. For those of Dexter Avenue and others who have known me sometime know that this is very dear to me, because my mother, who passed away in March of 2017, suffered from kidney disease. I can remember her having to go to dialysis, and those who are familiar with it know 3 times a week. Her days, I believe, were Monday, Wednesday, and Saturday, and she could not miss. She had to be there at a certain time, and we had to learn to work around that schedule, because it is a major life-changing adjustment for those who have to be on dialysis. And as I've shared with many of you, for us, it seemed as though it came out of nowhere, because we went to doctor's appointments and knew that she was suffering with high blood pressure and diabetes, but it seemed as though it was all of a sudden that she goes from being there to now having to be on dialysis. And so I wish we would have had places like this where we could come and receive the education so that we could be informed, because it puts you at a place where you feel powerless because you don't know. You don't know what to do. You don't know how to handle yourself. You don't know what information is out there. And often doctors, as they say, don't always have the best bedside manner when it pertains to informing you of these things and letting you know of the resources that are out there. So again, I want to thank you all of Dexter and from others who are here today to get the information, because you may not, and I pray that you never have to suffer with this, but there may be somebody in your family, there may be somebody that you are connected to, that you may be able to help them and take the information back to them and let them know you don't have to be powerless, but there are resources, there are questions that you can ask your doctor and make sure that you have the proper information. So again, thank you for those who are here, those who are on Zoom, and those who are on their way. Let us pray. Father God, we come to you right now. We thank you, Lord, for this day. I want to thank you, Lord, for allowing us to come together that we may be educated and we may be well informed when it pertains to our kidney health. We ask, oh God, that you would lead us and guide us and direct us, oh God, that we may be able to take this information and go and share it with someone else and be able to help someone else, that they may also be empowered and know that you have not given us the spirit of fear, but of power and of love and of a sound mind. Your word says, in all thy getting, get an understanding, oh God. And we thank you for helping us that we today may be able to get an understanding, that we may take care of our temples, that we may take care of this body and do all that we can to live the very best that you have ordained for us to be able to live. Bless all those who are here. Bless those who are on their way, oh God. We ask that you would keep us in your care. It is in Christ's name that we pray and we thank you. In Jesus' name, amen. Amen. At this time, I have the honor to turn it over to one of the greatest moderators I've seen. If you're not excited, he's going to get excited for you. Let us put our hands together and welcome Mr. And I forgot his first name that fast. I'm joking. Brother Wayne Tuckson. Amen.
Thank you very much, sir. Pastor White, thank you very much for that opening. It's clear to see why you're the president of the Council of Baptist Pastors of Detroit and the vicinity. Also want to thank you again for opening Dexter Avenue Baptist for part 2 of our community conversation on protecting health equity in kidney care and ensuring access to care and life-saving phosphate-lowering medicines within Medicare. Again, it's nice that you have again sponsoring this program along with the Council of Baptist Pastors of Detroit and vicinity. And this is also done in partnership with the healcollaborative and Artilex Pharmaceuticals. I am, as the pastor said, Wayne Tuckson. I have the pleasure of being the moderator for this program, and welcome to those of you who are watching through Zoom and also on Facebook. I'd like to bring up 2 people right now just for welcoming here. First is the Honorable Howard Mosby, who is the corporate treasurer and board member of the Heal Collaborative. Then we'll have Dr. Crystal Martin, who is a nephrologist, and I'll tell you more about both of them in a little bit. But first, Honorable Howard Mosby.
Good morning.
Good morning.
Good morning to virtual land. This is actually, it's great to be in person now, and I appreciate it. Pastor, we appreciate you again allowing us to be in your house. Again, my name is Howard Mosby. I'm from the Heal Collaborative, and we are here to actually provide the community with health education so that we can be healthy. One of the important parts of being able to advance our community is actually having a healthy community. If you're not healthy, you can't do a couple of things. You can't serve, and you can't tithe. Now, we are here in the church primarily because this is ground zero. This is where we start, and this is where our community has historically built its foundation. And we want to make sure that we pay homage to our community and how we got here today. So Heal Collaborative is here to ensure that communities of color are healthy, and we are just proud to lock arms with Pastor White to make this happen for this community here in Detroit. With that, sir, I will turn this back over to you, and we can move forward with the agenda. Thank you.
Thank you very much, sir. I will give a better introduction for Dr. Martin in a moment, but first let's just ask Dr. Martin to come on down here just to welcome us.
Good morning, everyone, and welcome. Thank you for coming today. I am very excited to give you the information needed to help take better care of you and your family in relation to chronic kidney disease. My biggest passion has been to try to get patients to actually prevent their progression or to identify the disease process. So we'll talk a little bit more about that in the near future, but I'm excited to give you that education and hopefully help you go out and touch the world and prevent kidney disease. Thanks.
We like to try to put things in perspective by hearing it. It's one thing for those of us who are treating or know someone who, but it really adds a little extra sauce, a little flavor when we actually hear it from the individual who's going through this process. Mr. Stokes, you can come on, start walking down now. We've been, fortunately, Mr. Alvin Stokes has been cajoled, coerced, and otherwise encouraged to come down there and share his journey as a kidney patient. Brother Stokes.
Amen. Thank you, sir. Appreciate it.
5 minutes is over.
Okay. Good morning.
Good morning.
I thank you, first of all, for this opportunity to share my story. I can go long or go short. Mr. Wayne said 5 minutes, so I'll try and keep it within that. I was diagnosed in 2010. Most people think of high blood pressure or diabetes as a kidney killer. I didn't have either, and I still don't have either. I was diagnosed with a rare blood disease. The blood disease shows up in black men over 40. It doesn't show up until you're over 40, and if you're a drinker, it doesn't show up at all. At that time, I was drinking. Once I decided to stop, the disease decided to show up. I went to the hospital thinking I was having chest pains. So I get to the hospital. Of course, I didn't have any insurance. So black men without insurance, we don't like to go to the hospital. But I went to the hospital at the time. They did blood work and sent me home. 4 o'clock in the morning, they called me. They said, we need you to come back. Your creatinine level was a little elevated. I'm like, creatinine? What is creatinine? So I'll go back. They draw it again and send me home again. So long story short, they ended up admitting me because I was still having these issues. I thank God for Nurse Mary Cox at that time, God rest her soul. She worked at Harper Hospital as a dialysis nurse. So I was able to confide in her. They put a catheter in me and sent me to dialysis, that your kidneys were shutting down. Now, mind you, most folks on dialysis, they retain fluid. Just the opposite with me. I was able to pass urine, but my kidneys weren't filtering. In other words, they weren't cleaning my blood. So I'm waking up every morning throwing up yellow mucus, which is poison, for those of you who don't know. So I'm like, what is going on here? So thank God for my sister, because I was at the receiving and they wanted to do a biopsy. So they come in that morning, they give me the medicine for the biopsy, come back about 4 hours later saying, the doctor to do the biopsy is not here, but the other one doesn't feel comfortable doing it. I was like, well, I don't want him to do it then. So my sister at that time called Dr. Olaf Kroneman, who's taking care of our entire family when it comes to kidney disease. He said, have him check out of receiving and check into Beaumont, and I'll take care of him. At that time, when I told receiving, I'm out, oh, we'll do it. I said, no, I don't want you to do it. I'm out. So I had to sign the release form, went to Beaumont. I spent about 3 months in between receiving and Beaumont in the hospital. And when they did the biopsy, that's how they found out that it was a rare blood disease that destroyed my kidneys. Like I said, they weren't filtering. So at that time, my creatinine, which determines your kidney function, for those of you who don't know, it was elevated up to about 5. So he puts the fistula in. I said, well, doc, what happens if I don't need it? He said, if you don't need it, sue me. So before it could heal, I had to go on dialysis. They put the catheter in, and now for those who are on dialysis have had this catheter, this is not something you want to play with. This is your lifeline. They have to use sterile gloves and everything when they're messing with this catheter. When they're putting you on dialysis, they can use the regular gloves or what have you. But with the catheter, it can get infected just by breathing on it. So, we went through that. They put the fistula in. I said, doc, I'm worried about, I've seen folks with these big old knots on their arms. He said, tell them to do buttonholes. Nobody ever heard of buttonholes. Buttonholes is just a little tunnel where they go through every time. So a nurse at that time at the dialysis clinic, she started the buttonholes. She only had 4 weeks left at the job. She started the buttonholes. And I didn't let everybody put me on. Folks would come over there and say, Ms. Stokes, did I put you on? No. There was only a certain number of folks, and I can count them on one hand, that would put me on dialysis. I told them, I said, if you come over here and you're not going to listen, don't come. I knew the direction to go for the buttonholes. I knew everything about it. This is my lifeline. I said, if you're not going to do what I asked of you, then I don't want you to take care of me. Nobody new could put me on or anything like that. I was like, no, this is my life, and I'm taking control of it. So a long story short, The last time at dialysis, they thought I had an infection. So they sent me to the hospital. And the old folks say they test me from the rooter to the tutor and found nothing at all. They couldn't find an infection even in the fistula. They sent me home that Friday, came to church that Sunday. Pastor asked me to do altar call. And the Lord heard my prayer, because at 6 o'clock Monday morning, they called me for a kidney. Nothing but God. Nothing but God. It'll be 8 years in November that I've had the transplant, and I thank God that everything is doing well. My mother and sister lost their kidneys to diabetes, my brother to high blood pressure. Well, like I said, I have neither, but God is good, and I thank him from where he's brought me from. Is that good enough? Thank you.
Boy, that's interesting. That is interesting, so many different levels. First off, I want you to talk. You mentioned about your family history of kidney disease. Tell us a little more about that, if you would, please. You started to at the end there, but how many people, and is this something that you all have talked about before and since?
Well, there's several folks in my family that are diabetics. And Dr. Croneman is taking care of all of us. My oldest brother, God rest his soul, he found Dr. Croneman. And he lost his to high blood pressure. My mother and sister lost theirs to diabetes. I had a brother, before he passed away, came from California. He thought he had kidney failure. We sent him to Dr. Croneman. Dr. Croneman said, I don't know what they're telling you, you're fine. And he was able to, start back. What would happen with him is he was taking ibuprofens on an empty stomach. And you can't do that. That'll shut your kidneys down real quick. Wow. And once he was able to, get food and everything in his system, and his kidneys started functioning right back. So he was fine. But everybody in my family that think they have a kidney issue goes to Dr. Croneman, and he takes care of all of us.
Do you think it is important that we include this as part of our discussion around the family table, the family reunion, about who has, given your experience in your family, that we talk about this to see who does have kidney problems?
It is very important that you talk about it amongst family, but thing is, black men don't get tested over 40 for this blood disease. They think, okay, I'm a diabetic or I have high blood pressure. But there is a blood disease that goes around in black men, and it does not show up until you're over 40. So, that's something else that we need to watch out for as black men. Dr. Croneman did a presentation. He said everybody has these chromosomes in their system that you can ruin your kidneys. It'll show up later in life. I was one of the, fortunate or unfortunate ones that I'm the only one in my family, and I'm the youngest of 12 to get this disease.
One last thing, if you don't mind, you seem like someone who's not too shy anyway. So, and I have a feeling Dr. Martin may give us a little discussion about some new biomarkers that are out there that may predict different types of renal disease. But tell us a little bit about you talked about how you took control of what was going on with your vascular access. And I think that's admirable. But tell us a little bit about the difference in quality of life as a dialysis patient versus the transplant patient. Well, patient who's had a transplant, rather.
Well, like the pastor said, dialysis, going there 3 times a week is time consuming. Right. And with me, like I said, they didn't have to take any fluid off. Although you have to watch them, because they'll go in there and they'll tell you, okay, I need to take some fluid off of you. Well, if you're already passing your urine, you're not retaining fluid. So they don't have to take fluid off of you, they just have to cleanse your blood. And that is something else that I had to get on the text about, because they wanted to take fluid off every time I went. And I was like, no, you can take the minimum amount off and that's it. You can't take no more, because you'll start cramping in a minute, and it's because they took too much fluid off. But it's something as black men, you know, like I said, we have no insurance. We have a tendency of not going to the doctor. And that is a major issue when it comes to black men as a whole. We need to start taking care of ourselves. With dialysis, like I said, it was time consuming. You're sitting there 3 days a week. With me, it was 3.5 hours.
Yeah.
There's nothing else to do. But now as a transplant patient, I have my life back.
Yeah.
I'm still have medication that I have to take the rest of my life, but my activities, I can still go out and do whatever it is that I want to do. I limited my restrictions as far as what I can do, but I'm still able to lead a normal and productive life.
I just want to make sure I got something straight before you go. You know, there are a lot of people who say on Sunday morning that they're here for you. They're going to take care of you. Who took you to when it was time to get your transplant?
It's funny, because at 6 o'clock in the morning, you don't want to wake anyone up. So the pastor had just gotten here in February. This happened in November. So at 6 o'clock in the morning, I said, I'm not calling him. I text him. Pastor called me back to have prayer with me. So then I reached out to my daughter. She was like, well, who's going with you? I was like, I don't know. She said, I'm dropping Ryan off. I'll be there as soon as I drop him off, and we're going. She stayed with me the whole time.
I just think it's remarkable, your story, and the fact that Pastor was there for you. That's remarkable. Thank you very, very much.
Thank you.
Thank you. I feel sorry for the next speaker, because I don't want to follow that guy. However, our speaker is going to be quite capable. We want to hear a little bit from one of our partners, Ardelex. So, we want to hear a little bit about what renal or kidney disease is really about, and look at the novel treatments, as well as discuss some of the followed by an residency at the same institution. Then she went on to do a fellowship in nephrology at University of Michigan Health Sciences Center. She is currently a practicing nephrologist with the Hypertension Nephrology Associates, and they have offices throughout all of Southeast Michigan. Today, Dr. Martin will be speaking to us about kidney failure and kidney dialysis management. Dr. Martin.
Okay, well, good morning again. So I would like to again start. Mr. Stokes gave an excellent testimony. I see this happen all of the time. Number one, Black men not coming to see the doctor. People who don't have access. He was lucky to have a doctor that was close with his family that helped him navigate through the system and made sure he was able to get access to nephrologists that actually cared. I could tell you more than likely that doctor held those nephrologists accountable, because I can't tell you how many of my patients, the doctor may mention transplant to them once, and they're like, oh, I don't want a transplant, because they're still in denial about needing dialysis, or they've gotten cut on. And then you ask them once, they're like, fine, and they never ask you again. The government's putting things in place to try to encourage transplants, but it has to be continuously discussed with the patients, because patients do better with transplants than without. But let's start to talk on chronic kidney disease. So chronic kidney disease, one more. But chronic kidney disease, when you're talking about chronic, that means this already established or irreversible damage done to your kidneys. And if you don't diagnose it, or it's not diagnosed early, then they can't put things in place, or you can't make the changes you need to prevent progression. Or in some cases, it may be too far gone where you have to initiate dialysis. So it is important to see the physician to hold them accountable, to get your lab work and start asking questions. If there's a lab work and it has an H next to it, what's that H? High. Creatinine, like you said. That's high. Why is that? What are we doing about it, right? Because the earlier we find it, the sooner we can put things in place to try to prevent the progression. Next slide, please. So people say kidneys, okay, well, I'm making urine. My kidneys are fine. What are you talking about? But kidneys do more than just make urine. There are 5 things that kidneys do. Yes, they make urine to get rid of waste products and to adjust your volume, but it's also important in controlling your blood pressure, getting rid of extra sodium that we as people of color tend to have a tendency to hold on to salt, which makes us hold on to water, which may increase your blood volume. It can cause increased blood pressure. Well, it corrects that. It adjusts electrolytes, because it's your potassium. It also affects the acid and bicarbonate, so how acidy your body may be or your blood may be. Kidneys neutralize that. So when you eat a very high protein or red meat, that breaks down the acid. The kidney knows how to get rid of that extra acid, so you stay at a certain level. It also creates the hormone that tells your body to make blood cells. So if you start having kidney disease, you may become more anemic. I've had patients that were anemic and they said, oh, it's probably your menstrual cycle, or it's probably maybe something in your stomach. They didn't put 2 and 2 together that it was their creatinine of 5 or 3. That means they have chronic kidney disease and their body wasn't making this hormone. And lastly, it also affects the bones. It makes vitamin D. And when the kidneys aren't working, your phosphorus goes up, you're not able to make the vitamin D, your bones start to get weak. But we're going to talk about the phosphorus and how important that is when the kidneys can't get rid of that and the other signals that it does, that it sends to the body and makes changes. Next slide. So, as we had mentioned before, we are about 13% of the American population, but Blacks make up 35% of the dialysis population in the United States. Why is that? Next slide. Because we suffer more from the 2 top causes of kidney disease, which are the 2 most preventable causes, hypertension and diabetes. Again, why is that? Well, a lot of it has to do with social, disparity, healthcare disparities, but it also has to do with what we eat, the stress in the environment. Also finding out when we have high blood pressure, because again, a lot of us don't go to the doctor, or your blood pressure is high and they say, well, doc, I don't want to take a pill. Well, I don't want to take another pill. But you're still going to McDonald's. You're still adding white salt to your food, but you're wondering why your blood pressure is still high and you don't want to take a pill. Sometimes you have to realize those pills are going to save you, not hurt you. You have to have a doctor you can talk to that talks about the side effects, and when you have them, guess what? We have a lot of other medications we can give you that you may not have the side effects from. And they want to make sure they're giving you the right meds. And your goals. Know your goal blood pressure. Anything with a blood pressure over 140 over 90 is hypertension. We usually check it twice. If you have 2 consistent blood pressure readings of greater than 140 over 90, you have hypertension. And if you're a Black person or a person of color with high blood pressure, you're at higher risk for going on to dialysis. So it has to be addressed, and it has to be on the right medications that are going to be kidney protective. Diabetes. And by the way, in Blacks, it is hard to control the blood pressure in Black patients. That's why a lot of times we will need more medications than just one. Diabetes. We're also higher risk, and it's hard to control. A lot of it is cultural. A lot of it is what we eat. Obesity is associated with diabetes. And we have to first recognize we have it, again, not be in denial, and take the right medications we need to keep that sugars under control. It is a time when you want to make your lifestyle changes the minute you get diagnosed with diabetes, which means exercise, decreasing your carbs, get away from those pops and sugary drinks. And we talked about family history. You have to know your family history, because if you have a strong family history of diabetes, your risk of getting it is much higher. If you have a strong family history of high blood pressure, you have a high risk of getting it. Start letting go of the salt. My kids and I, when I turned around 40 and I was teaching my kids, from when I learned as a nephrologist, we don't use salt. We don't add salt to our foods. They started doing that right away. Why? Because we know that we have a strong family history. We don't want it. And when they saw my patients, or I see when my patients suffer from that, and from what I've learned, we let go of the salt. I implore you to do the same thing. Same thing with diabetes, strong family history. So I watch my carbs. I stay away from bread, pastas, rice, things in moderation. You have to take control of your life and say, do I eat to live or do I live to eat? Especially after the age of 40, because that's when all these things start happening. And unfortunately, especially with hypertension, because our kids are eating all this salt, fast foods when I was little was a treat. You go on a road trip, you get that, your father may be like, oh, look, I brought home McDonald's. They're eating McDonald's every day, which is a salt load. So why am I seeing 15-year-olds with kidney disease and hypertension? Why am I seeing, but we used to see when we were in the 30s and 40s, middle age, we're seeing 16-year-olds with diabetes, adult onset type diabetes, because of what they're eating. And again, the hypertension. I have patients that are 18 on dialysis. And it's happening at younger and younger ages now. So again, we are what we eat, and we eat to live, not live to eat. So we have to start taking that seriously. The obesity, about 80% in Black men and women are obese. And when you're obese, you have a 20% higher risk of developing chronic kidney disease over the next 20 years. So again, being conscientious of that, what do we have to do? What lifestyle changes do we have to make? Because nobody wants to be on dialysis. So why do we not want to do what we need to do to stay off dialysis? Genetic predisposition, which Mr. Stokes talked about. There's especially, so now the good news is there's ways that we can evaluate for these genetic predispositions. There's an APOL1 protein that is very common in the Black community. It's associated with a disease called focal segmental glomerular sclerosis, or FSGS. And if you have that gene, then that means you have a higher risk. There can be a second hit or mutation that can occur that will cause you to now spill protein in your urine, develop hypertension, and potentially go on to dialysis. So we do screening, and we find people who have that gene. I've done genetic counseling with them, where I said, okay, now if you have that, your kids may have it. So bring the kids in and let's talk about low-salt diets. Let's talk about staying healthy. Let's talk about eating the right things. Because if they develop hypertension, don't take care of it, that person could end up on dialysis because they have that genetic predisposition. Also, things like polycystic kidney disease. That's an autosomal dominant disease disorder. That means you got a gene and it's going to show itself and cause these abnormalities in your body. So you have to be cognizant of the family history, which you mentioned, so important. Back in the day, they didn't ever, the adults never wanted to talk about it. They didn't want people to know their business. We have to share our business because it's the difference in making changes early. And like I said, my kids were like 10 years old going to school like, oh, your mother put salt in your food. She don't love you. She's trying to kill you. And they were serious. They were like, oh my gosh, no, you can't use salt. I hide salt when I go to parties, we go to organization dinners, and some people will tell you, yes, she sure does. I will see salt on the table when we're at a dinner, and I'll put it on the table and say, nobody's using salt at this table because I don't want you to die. I don't want you to develop high blood pressure. People will tell me, oh, my blood pressure is good right now. Yeah, right now. But that doesn't mean it's going to be good 3 years, 5 years, or your body's not making changes because of the excess salt exposure that's going to expose itself later, which is what is happening to our kids. Also, other types of autoimmune diseases that can come out the blue. Lupus. People who have a family history of lupus need to know that, but lupus is another disease disorder, autoimmune disease, that strikes hard in the Black community. When Black patients have lupus, they're more likely to develop chronic kidney disease than their white counterparts. They're more likely to suffer the complications and even potentially death. And then there's other autoimmune diseases that I won't go into. Next. So when we talk about healthcare disparities, there's another reason why as Black people we're at higher risk for a lot of these disease disorders. It is by design, unfortunately. How many doctor's offices do you see around in our neighborhood? How many grocery stores with healthy foods do we see in our neighborhoods? Wow. How many mom and pop shops, pharmacies do we have in our neighborhood? Because guess what? When CVS and Walgreens came, they put them out of business. But guess what my mom and pop shops used to do? Oh, Mr. Stokes, I saw you ran out of your blood pressure medication. I'm going to call here and call your doctor and ask him to give you a refill. Nowadays, my patients come back, blood pressure is 180 over 110. Well, what happened? Well, I don't know. You stopped this medication. I didn't stop the medication. Oh, you ran out of refills. Why didn't you let me know, or your pharmacy let me know you needed these refills? Because sometimes patients will be oh, that's one less pill I have to take. I don't really want to say anything. But my mom and pop, they used to call those patients and say, hey, you need this. Or they say, I'm called your doctor. Also, life-saving medications. I've had patients that try to put on medications that will help decrease the progression of kidney disease. All it needed was a prior authorization. Those patients came, the pharmacist said, oh, you owe me $600 for the medication. Oh, Dr. Martin must be crazy. They turn around and they don't get it. I see them 3 months later. Why didn't you get the medication? Oh, the pharmacy told me it's going to cost this. Oh, all you need is a prior authorization. All I need is to justify why I'm giving you this medication. Why didn't the pharmacy call me and tell me that? I call the pharmacy. We need a prior auth. Oh, hypertension, diabetes, kidney disease. Okay, it's cleared. $2. All that the pharmacy had to do was contact me. Yep. So again, there's a lot of social disparities that are determined. So those are the non-medical causes of us to do not as well. If you don't have a relationship, if you don't have good food around you, if you don't have parks to take your walks because it's not safe in your environment, then how are you going to exercise, right? How are you going to, your kids need fresh air. If you live in a city that has a lot of pollution, then they're going to do worse. That's why some people out in the suburbs and some people are not in the suburbs, they are having worse outcomes, more likely to get asthma or emphysema, other diseases such things. Also, having a good church base. Guess what churches do? They provide health care. They provide education like today, praise God. Because then sometimes you'll hear things that you never would have heard. Sometimes the health fairs will go and patients will come in, oh, wow, my blood pressure is what? I didn't know that. That's the time when patients that don't have insurance come and find out what they need to know. And they're like, oh, I have blood pressure. Okay, what do we need to do? And then we have resources out there to provide those that don't have insurance or how to navigate to get insurance. Next slide. So I know this is a lot. We have kidney cards in the back, but this is what I try to hand out to patients to tell them, ask your doctors. This is what I do, health talks, health fairs. My patients already know this. We go to this all the time because I say, look at here, look at the side which talks about which stage kidney disease you have, and then look at the top that talks about how much protein or albumin is in your urine. It's very important that, especially if you have diabetes, that your doctor's checking for urine albumin at least twice a year, depending on your level of kidney disease, because that tells us your risk. If you have no protein and you're in stage 1 or stage 2 kidney disease, you're good to go. That's green. This makes it easy. Green, yellow, orange, red. Green is good to go. You're doing great, low risk for progression. If you start to have protein in your urine, even as little bit as 30 to 300 milligrams, you're already at moderate risk. If you have greater than 300, then you're at high risk. That's the orange. And then if you're at stage 4 kidney disease or 5, you're already at high risk. And especially if you're spilling a bunch of protein. You can see even in stage 3 kidney disease, which is between 45 and 60% kidney function, but sometimes we're like high 5, but if you have 300 to 3 grams of protein in urine, we start talking about we're probably going to progress on to dialysis, unfortunately. Next slide. And those are the 5 stages of progression of kidney disease. Next slide. Very good. So what happens when you progress on to needing renal replacement therapy? Well, then you have to think about hemodialysis, which is what Mr. Stokes was talking about. God forbid, the reason we want to catch it early, and if we can't progress it, we can't stop the progression, we want to get you prepared early so that you don't end up with what he called was a permacath in your chest. I had a 30-year-old who kept a perm cath because when she got to dialysis, you're like, ooh, I don't want to get that in my arm, and I don't want to be stuck with needles. So I have a right as a patient to say no, and I'm just going to keep this catheter. A year and a half later, she's having open heart surgery and has to have her valve replaced because the bacteria held onto that valve. Wow. Then she's like, okay, Dr. Martin, I guess I'll go ahead. Well, actually, she was being taken one of my partners, and I was like, we don't do catheters for 2 years. So actually, we switched her over to the stomach dialysis, but we'll talk about that. So when we talk about hemodialysis, what Mr. Stokes failed to tell you was, don't forget you had to arrive at dialysis a half an hour ahead of time. Sometimes your transportation took you there an hour and a half ahead of time because it built in to their convenience. And then you had to wait for them to come pick you up, which may take an hour. So you actually were around for 4 or 5 hours, but the 3.5 was on the machine. So when you do that, we have to create an access in the arm, and you do go to the center as he stated. We now have home hemodialysis, which is actually an excellent alternative because you do it at home. You may do it for 4 to 5 days a week, and you only do it for 2 to 3 hours, and you do it at home. We teach you how to access, sometimes through buttonholes, sometimes how to access your fistula or graft yourself, and you do that, and you never gain a whole lot of fluid if you're a non-producer of urine, or you measure yourself and you figure out how much you have to take off, and you do it at home. And those patients do well. We've had patients who lived on home dialysis for like 10, 15, 20 years when they have a rare disorder where they couldn't get a kidney because of their blood type. I used to have a nocturnal dialysis on 7 Mile, Illinois, where my patients will come in and do 8 hours. It's almost like with the home where you're getting good, long dialysis treatments that are not as hard on their body or on your heart. So those patients had better clearances, better numbers, and lived longer, did better. The same side. And then there's in-center versus home dialysis. Next slide. The peritoneal dialysis is what we did for the patient because I didn't want her to have another catheter and she didn't have this. This is what you do at home as well, and it's a stomach dialysis. And you see there, this guy actually has a cycler, where what they do is they have this catheter, it goes into your belly, it sits in the pelvis area, you don't feel it. It's probably like this, but more like a flimsy material, but about this thick. And it sits there, and there's the CAPD, or ambulatory, where you put the fluid in, it sits on your bowels, and you have vessels there. It's an open pouch, right, in your stomach area, the peritoneum. And it sits on there, and it cleans the blood, and then you release those toxins through that material every 6 hours. But this one he has is called a cycler, which my patients love because what they do, they can take it with them on vacation. My patients travel. They have the bags flown to wherever they're going to be. They connect like you would a pin, unhook one, put it on, and then they sit in their bed till they fall asleep, watch movies, and while they're sleeping, it cleans the blood for them for 8 hours. And then they unhook and they go about their business. They go to work. They go to the movies. They go hang out. They live their life. And they can adjust how they want to do it and what times they want to do it based on their lifestyle. And they do very well as well. And I tell people too, because I'm always pro-transplant, it's easier to take a catheter out your stomach and put a new kidney in, as opposed to these catheters that get blocked up, get ripped out your chest, got put back in, you got to rip it out your chest, put another one in when they're not working. And patients who start dialysis with those perm casts we talked about, they have a 20% higher risk of mortality the first year. So we always want to avoid those catheters and get them out as quickly as possible. Next slide, and I think I only have 2 more before you tell me time up. You warned us. So this, transplant is first, always, right? We should always be trying to get a kidney transplant. Why? Because kidney transplants live longer and do better. So if you see here in the green is a living-related transplant, that bar, and that's at 1 year, life survival. 2nd year, 5 years later, and then 10 years later, they do better. Now, people with chronic kidney disease have a risk for cardiovascular disease. They don't die from kidney failure, they die from heart attacks most of the time, or infections. So that goes hand in hand. So when you see these numbers in people's death, a lot of that is heart disease or infection. But the blue bar is those who got a deceased donor, who they got a kidney from somebody who unfortunately passed. Again, they still are closer to the living-related donor, but they still do better than the red bar, which is dialysis. And you see the percentage of patients after 10 years they're on dialysis is very low compared to the others. So transplant should be the first thing. You can get evaluated for a kidney transplant when your kidney function is less than 30. They won't list you till it's less than 20. What I try to do is get my patients the minute it looks like they're progressing, especially if they're 25 or 20% kidney function or less. I get them evaluated, they get listed at less than 20, and then we try to prolong the time until their kidneys worsen for at least 3 to 5 years, maybe even 6 if we can, because unfortunately, especially in the Michigan area, in Black patients, it's about 6-year waiting time to get a kidney transplant if you don't have a potential donor. But I also have patients that we're like, okay, but we're not going to take this. We're also going to go get multi-state listed. So I'll send them to Toledo, Ohio to get listed. I had one patient who was going on his 5th transplant center when he got called by Johns Hopkins. But he was listed here in Michigan, he was listed in Ohio, he was listed in Wisconsin, and he was listed in Maryland and was working on the next. Again, because he knew, because unfortunately his kidneys got worse very quickly, something unfortunately happened to him. So while we had listed him when he was at less than 20%, he ended up having to do peritoneal dialysis for about a year, and then got his kidney transplant. But when I rejoice is when I could avoid. And I've had some patients that never saw a dialysis machine. They went straight for a kidney transplant. And that's what your nephrologist should always be trying to aim for, especially if they catch you early. You do not have to wait until you're on dialysis to get evaluated for a kidney transplant. Next slide. So why is this an exciting time to be a nephrologist? Because you've heard this, you're like, oh, that kidney disease, this is terrible. One, I tell people kidney disease and dialysis is a lifestyle change. It's not a death sentence. But even now, more reason for you to know your numbers, to talk to your doctors, to know if you have chronic kidney disease now is because there are a lot more medications over the last 3 to 5 years that have come out that actually we're thinking may stop the progression and prevent patients from going on to dialysis. So again, when your doctor's talking to you about meds and you're thinking, I don't want another med, you make sure to ask them, is this one of those meds that's going to stop my kidney disease, that's going to get rid of the protein in my urine? Is it going to protect my kidneys? And if that's one of those meds, don't say no. In fact, I tell my patients to actually ask for it. I mean, they ask me, but I do healthcare, so I'm telling people, ask for these meds. And in the interest of time, I did not list all of these meds. In the other health fair, I was like this, and one of the audience said, oh, my doctor tried to put me on that. I said, no. I was like, oh, you're crazy. By the end of our discussion, I'm calling my doctor now. I'm going to get back on that. I'm going to tell them to give me that medication. Next last slide. So how we help fight kidney disease, how do I help you help your doctor take better care of you? Know your labs. Get your labs and say, what is this? You pay them a lot. And if they don't want to answer, say either you send me somebody who's going to answer my questions or you find another doctor.
Amen.
Because I've had patients that come to me, their kidneys are already dead. I'm calling the doctor like, well, why didn't you send them to me 2 years ago? Oh, don't worry about it. As soon as you start dialysis. No, but their blood pressure was under control. You didn't have all of these protective medications. We could have prevented this. I used to get upset. I lost a lot of referrals because I used to call the kid. By that time, I was yelling at the doctors like, are you kidding me? Also, he mentioned non-steroidals, Motrin, ibuprofen, Excedrin, Aleve, Celebrex, naproxen. Those medications should not be taken in patients who have diabetes and hypertension. One, they increase your blood pressure because of their effects on the kidneys. They can expedite the demise of your kidney. I have a patient that ended up on dialysis just from taking non-steroidals. And they always, especially in diabetics, because of their high risk for going on to dialysis, that those medications, since they can be toxic to the kidney, should be avoided. Know your goal blood pressure, know your goal blood sugars, or hemoglobin A1C. Our goal is at least to be less than 6.5. Sometimes that's your 3-month average that tells us. So we're supposed to be screening patients, even actually over the age of 18. If you're obese or you have risk factors, we start screening for diabetes because it's so important to catch this early. Know what your blood pressure goal, if you have chronic kidney disease, or in general, should be less than 140 over 90. And then we also try to aim for, especially in blacks, because of high risk, about 130 over 80. Let's see, what else I say? Know your urine albumin creatinine ratio. Make sure, especially if diabetes, that your doctor's checking it. But even if you don't have it, if they're not checking urine, like Mr. Stokes said, sometimes that they do a dipstick or they check the protein in urine, and we may find out you have a lot, and it's some other disorder that's not associated with hypertension and diabetes. So we really try to teach doctors to start checking for those urine albumins. Because the kidneys and the heart are so in tune, when you see protein in the urine, that actually means you're at higher risk for cardiovascular disease. Maintain your low salt diet. Anybody of color? Definitely no salt. Leave the white salt low. 680 milligrams in the fourth of a teaspoon in Morton's. Sea salt, is that better? It's just less processed, but it's still 550 milligrams of sodium in a fourth of a teaspoon. So you have to be careful. Am I saying, can I be realistic? Okay. Yeah, you're not going to not put some. But I tell people Old Bay seasoning only has 180 milligrams of sodium. Seasoned salt, like Lawry's, 330. Make sure you're looking for the low salt brands if you're going to add seasoning and trying to use other. Unfortunately, a lot of us only know salt and pepper. We have to know our other herbs and spices that will help enhance the flavor of the food so you don't feel like you're, giving up, a good thing in life. But again, eat to live, not live to eat. And God's Kool-Aid, I always talk about water. Okay? He made that. He didn't make Kool-Aid. He didn't make pop. He didn't make the sweetened teas. So just letting you know. And then lastly, maintain a healthy weight, exercise, and know your kidney numbers. And if it's less than 60% kidney function, or if you have protein in the urine, ask to see a nephrologist so we can work to help you stay away from dialysis. and help your doctor take better care of you. Thank you.
Outstanding. We will have time for questions later on, so don't think that she's getting away right now. She's going to be on a panel. We're going to all have some time for little questions. Let me remind everyone, in the packets there was a evaluation form. There's a pre and there's a post. Don't cheat and fill out the post now, but do fill out the pre-evaluation for us. That's very, very important for us to help us determine what's going on and tell us how we're doing with things. So if you can fill out, make sure that you do that, and at the end of the program, fill out the post-evaluation. Out of curiosity, how many people here know what their hemoglobin A1C is? Okay, that's about a fifth. How many people know what your creatinine level is? Again, even lower number. So we have some work to do on a few things. Ordinarily, I would be worried for our next speaker, after coming behind Dr. Martin and Mr. Stokes, but I have confidence that Dr. Alan Ryan, who is Dr. Sanders, you'll appreciate this. He earned his BS in pharmacy at the Mecca. Those of you who know, that's Howard University. If you care to know where I went to undergrad and medical school, you can guess. But anyway, Dr. Ryan earned his BS in pharmacy at Howard University. And this was following, and then he got a calling. And he then obtained a Master of Leadership and Master in Divinity, both from the Luther Rice Seminary. This was then followed by a doctorate in educational ministries at the Dallas Theological Seminary. Dr. Ryan is currently the Senior Director of Patient Advocacy at Artilex, and Dr. Ryan will speak on hyperphosphatemia management and kind of explain to us what's going on as far as the medical treatment for this. Dr. Ryan, thank you.
Thank you, my brother. Good morning, everyone. I'm so glad to be here this morning. I have to say it's really almost a dream come true to see good health information just being continuing to pushed into our community. We know that if we're going to reach our people, it has to be through the church, yes? And so it's just wonderful you all have a pastor here who believes in that and is really taking care of his people. Amen? Give him a hand clap of praise, please. Yes. And Dr. Martin's presentation was so good, I now have fewer slides. Amen. I'll catch us up a little bit. Yes, if you put up my first slide, the next slide would be great. There we go. So the headline of this slide is Our Patients Deserve Better, and what you see there is a picture of my grandmother, Mama Joyce. And why is Mama Joyce up there? Well, when I was in high school, I lived with Mama Joyce, and my job was to drive her back and forth to kidney dialysis. And so as I went to pharmacy school at Howard, I was her, let's just say, sounding board as she was trying to make the healthcare journey, and she had her thyroid removed and all of these things that went along with her reality. She was a diabetic patient, and so she's gone on to be with the Lord and some years ago. And so candidly for me, I was retiring out of working at a large pharmaceutical company and about to just frankly have a casual lifestyle, but then let's just say I got a call. And so it's really been a blessing to work in this space where we're authentically able to try to help bring good information to or support organizations that bring good information to our community. And working in this area that, frankly, personally for me, was an area of real concern. Dr. Martin has already shared how African Americans are disproportionately impacted by kidney disease. It is the 9th leading cause of death in the United States. You can keep the slide up. It is the 9th leading cause of death in the United States. There are over 500,000 people on dialysis, and approximately half of those pass in 5 years. So it is a very serious matter once you are on dialysis. Next slide. And most of these statistics have been covered. Other than the African Americans are 3.5 to 4 times more likely to develop kidney failure. So it's, this really hits our community hard. Even on the ride over here, the gentleman who was driving me was asking me, what am I doing? I said, well, there's a kidney health event at a church. And then he began to tell me about his family and the realities that he's experiencing in his family regarding this frankly, life-changing situation for many. So we're all aware of this. How many people here have someone in their family that they know themselves that are impacted by kidney dialysis? Raise your hand. Yeah, see, it's very, very prominent. So next slide. Dr. Martin already talked about this. Diabetes and high blood pressure are the predominant causes of kidney disease. Next slide. And one other cause, I put this picture here, is that they're finding that people who work in the hot sun day and night, shall we say, or work jobs that require them to ultimately get dehydrated on a regular basis, frankly, they have found that more of those individuals are impacted by chronic kidney disease as well. Next slide. We already covered this. Next slide. Now, this slide, you can't read the font, it's too small, but you can see the bar chart there. Now, the bar chart, each bar represents the likelihood of death. So the bigger the bar, the more death. And unfortunately, what it shows is that blue bar is normal, the normal rate of death based on how much phosphorus you have in your blood. So the kidneys filter out phosphorus. So that way, when you have normal functioning kidneys, you would have the blue bar. But once you don't have normal functioning kidneys, then you're going to have a tendency to accumulate phosphorus in your blood, and then your likelihood of high phosphorus goes up. And as your high phosphorus goes up, so does, unfortunately, your risk of death. Each bar that's represented there as the stair steps go up, it's in correspondence with how much phosphorus is in your blood. So the more phosphorus is in your blood on an ongoing basis, it just dramatically increases your likelihood of death. And so having your phosphorus well managed is a key thing and an ongoing thing that every chronic kidney patient has to deal with. And if you're a chronic kidney patient, you know this already, but for those of you who are not, this is a very real issue for patients who are getting dialysis on a regular basis. So the next slide. And this slide just shows that of the risk factors for chronic kidney disease, basically the orange is extra phosphorus, meaning it's the largest risk factor, as opposed to anemia or some of these other things that have to also be managed, right? So you have multiple things that have to be managed when you're a patient that's a dialysis patient. But if you don't manage the phosphorus in your blood, it's one of the most serious things you can, frankly, not take care of. So you have to take care of your phosphorus levels in your blood when you are a dialysis patient. So the next slide. And so the company that I work for, Ardelyx, they launched a new product last fall called Exfosa. And this product is a new drug class. It's a new way of lowering the phosphorus in your blood. Now the traditional way is called phosphate binders. And what a binder is exactly what it says. It binds to the phosphate in your food. So as you're eating your meal, you take the white pills on the white pills there. You take the white pills with your food, and then it binds to the phosphorus in your food and doesn't allow it to go into your blood. Whereas Exfosa, which is the new product, it is our product. It essentially has your body say, I don't want to accept the phosphorus. So it works in a different way than the binders. And so the phosphate binders are something you have to take with every meal. Our product, you take it twice a day, and it's a much smaller pill. So the bottom line is it's something that you can take in addition to the phosphate binders, because the goal is always to make sure that phosphorus is maintained within a normal level. So you can take it in addition to the phosphate binders, or you can take it in place of the phosphate binders if you need to. And so the bottom line is this is available now, and I will say there's going to be a conversation soon about clinical trial diversity. One of the things that really impressed me about what this company has done is, in clinical trials, it's very common to get drugs approved frankly, even for, candidly, diseases that we are impacted by in large number. And then the trials will be done with only 3 or 5% African Americans in the trial. That's very common, right? Well, in the trials for this drug, they had over 40% African Americans in the trials. So we know the drug works for us, okay? So they took the time and made the effort to make sure that that happened. Now the drug is available and on the market. And if you want more information, just check the website, you know how that works. And so the next slide. What's happening? So this is where my friend and colleague Matt Lash, raise your hand. He's here today too. We're going to be talking more about this, I'm sure, in the panel, but just to share a little bit about it. Basically, when you get your dialysis treatments, the government has it set up where you get what's called a bundle, the provider gets what's called a bundled payment for your dialysis treatment. Now, you can substitute the word bundle for fixed. So pretty much a standard payment for when you go to get dialysis treatment. Now that can be an okay thing, but the problem is once you take that fixed payment or that bundled payment and then you start wanting to add more things into it to say, well, not only do you have to do A and B for the bundled payment, now you have to do A, B, and C for the bundled payment. Now you have to do A, B, C, and D for the bundled payment. Well, you know what's going to happen, right? So somehow things are going to start getting managed to a lower and lower level because you can't just keep adding more things to the same payment rate, yes? So essentially what's happening is, well, what has happened in the past is Congress had it set up where oral drugs would not be included in this payment bundle, and so therefore dialysis patients could go to their pharmacy and get the drugs they needed, and they would be reimbursed through the standard methods, Part D, Medicare Part D. And so now that law that's standing today is scheduled to expire at the end of the year. And since it's scheduled to expire at the end of the year, what that means is that come January 1, CMS is going to start putting these oral products, these oral drugs that are not taken during the dialysis moment, and they're going to ask or require that they be reimbursed through this fixed bundled payment. And so it doesn't make sense clinically because during the dialysis session is not when you take your oral medicines for your phosphate management. That's not how it works. And so it's going to cause, let's just say, a challenge to the physician-patient choice and individual and making sure that each patient gets what they need, right? And so that's in part why we're here, is to make sure everyone is aware that this is pending, right? And Congress is in a position to take action to continue what they had already had in place, right? But we know right now, Congress is not functioning so well, right? Unfortunately, right? Right? So getting their attention to do things that are just what we would consider basic and ordinary things now become a heavy lift, right? And so, and I know we're going to talk more about this, but I'll just make this comment. Silence is agreement, right? So if you don't speak up, then whatever is going on is what is assumed to be okay. So as was shared earlier with the gentleman who was talking about controlling his health care, we have to take control of our own space, right? And we have to be at least heard. You're not going to always win, but you'll at least have to be heard. And so this is something where we are trying to get the word out and support those who want to speak about this and get the word out about it as well. And happy to be part of this conversation, and turn it back over to Dr. Tuckson.
Pastor White, there's a TV show that started 2023 on the Paramount Network. It was called Lawman Bass Reeves. I don't know, did any of y'all see this? Y'all know who Bass Reeves was? If you've ever heard of the Lone Ranger, they based that on Bass Reeves. Bass Reeves still lives. He's here. Our keynote speaker is one of them guys. Legends. In truth. I mean, he won't say it, but I will. Dr. Lawrence Sanders. Dr. Sanders received his MD degree from Vanderbilt University College of Medicine, completed his residency in internal medicine at Emory University College of Medicine, then earned a Master of Business Administration from the Wharton School of Business at the University of Pennsylvania in Philadelphia. The reason I say he's a bad guy because he is recognized by his peers for the excellence of which he brings to the table. He is past president of the Atlanta Medical Society, of the Georgia State Medical Associations. And in 2014, he was installed as the 115th president of the National Medical Association, which is the largest organization of African American physicians in the country. Dr. Sanders is currently the physician advisor for clinical documentation, improvement, care management, and hospital throughput for Grady Hospital Systems in Atlanta. In other words, he's the guy that gets stuff done. He is also the Chief Medical Officer for healcollaborative. Dr. Sanders will tell us a little bit about diversity in clinical.
Good morning. Good morning. Well, I'm going to start by very much for the introduction. And one of the things I remember is that when I was growing up, and this will date me just a little bit, but one of the things my father would do would be play records of Martin Luther King, and that's how we kind of learned a good number of things. And one of the things I heard after an introduction was this statement to say, I hope that's true, but if not, thank God for the rumor. All right, and so what I would say, first giving honor to God that gives us the reason to be here, and to the pastor who opened up this church for us to have the opportunity to talk. I want to step back for a few minutes. You've heard from a patient. You've heard from a physician who talked about chronic kidney disease. And in Dr. Martin's talk, she talked about the number of new treatments that have come forward over the last years. You heard from Ardelyx about their new medication and how that came about. And what I want to spend the next few minutes talking to you about is how do we get new medicines, and why is it important that we participate? And the tool that we use is something called clinical trials. So I want to just make sure we all understand what clinical trials are, why they are important, how they work, how do you access a clinical trial, and even more importantly, why should we participate? So those are the things that I want to accomplish over the next few minutes. All right, so let's start with clinical trials. Let's get a definition, one that we can work with, an understanding of what clinical trials are. First of all, I'm going to say clinical trials are a kind of research. And so often when we talk about research, most of us recoil for a number of reasons. Because so many times in our history, research has been used for many different purposes. But let's look back and look at the benefits of research. Now, research is nothing foreign. I think Mr. Scott said it very well. When he was getting his treatment, he figured out what was needed to be done, that he got what he needed and held to those principles. That's really taking an idea, testing it, and learning how to make it better. That's what research is. So clinical trials represent the kind of research that involve human beings or people, and it's called clinical research. There are two types of clinical research. One is we'll observe a disease as it progresses. The second one is we look at ways to improve our treatments of that disease, and that's what's called clinical trials, okay? So now that we know what a clinical trial is, it is really a way to test not just new medications, but new treatments. Part of the way that we learn that salt adds to blood pressure and other problems is by comparing the people, observing the people who didn't use salt and the people who use salt. That's a clinical trial. So it's not really limited to medication. It's really all kinds of things. It could be prevention, it could be surgery, it could be what you do after you get the disease, but it's the way we learn to improve what we do. So how do clinical trials happen? There are basically 4 phases. Somebody has an idea. Let's stick with drugs. Somebody has a new drug, or a company has a new drug that they want to try. The first thing they got to do is make sure it's safe. Make sure it's safe. Understand what the side effects are. find the right dose. And so they do that first phase called phase 1 among healthy people to see what it causes that could go wrong, what are the problems it might cause, and to find the right dose. The second part of the clinical trial is called phase 2, but then we look at, and we want to make sure it works or that it's effective. So then we begin to look at it among people who have a certain disease or a certain condition, or to look at a certain process that we're doing to make sure that it works. It has to be effective. So first 2 phases of clinical trial, safety and effectiveness. Those are relatively small studies involving anywhere from, I'd say, 50 to 300 people in each of those. Now, once we know that it's safe, once we know that it's effective, we need to look at it at a broader group of people who have the condition or disease to make sure it works across a wide range of situations. And that's what we call phase 3. We continue to look at safety, we continue to look at effectiveness, but we begin to look at how it interacts with a number of other things. Now, some people say, well, that's about genetics. We've heard about genetics. We say, well, we have different genes and things work differently with genes. But I would value to say, yes, genes are important, but it's also about where you live, what you eat, what your environment is like, because all of those things impact. So we really have to look at this across a broad range of people, and that's why all of us need to think about participating in clinical trials, because it looks at how it operates against a wide range of people, and not only how it benefits us, but it's also how it benefits those who are us, if that makes sense. All right? So that's phase 1, phase 2, and phase 3. You've heard me use the word safety and effective in all of those, plus looking at how it impacts everybody. Now, usually after phase 3, the drug gets approved, and we move to phase. And when you use it more, we can affect it. We continue to look at its safety to really understand, and it really isn't in some situations until we get to that phase 4, all of the side effects. So phase 1, 2, phase 3, safety. Now let's take a step back. I think Dr. Martin laid it out very well, the new drugs to treat chronic kidney disease. But let's take a step back. I remember when there were only 2 or 3 drugs, and I'm going to date myself a little bit further, to treat hypertension. Now today, we've got a wide range of drugs to treat hypertension, and all of those came as a result of clinical trials. If I go back and I look at antibiotics, in the 1940s, there weren't a lot of antibiotics. We started to develop antibiotics, and we developed those by studying them and looking at them. And today, we have antibiotics or medicines that treat infections that are very specific. And they came about as a result of clinical trials. So, if clinical trials become our workhorse to improve what we do, why is it that we say we don't want to participate? All right? Now, before I go into talking about why we don't want to participate, I want to talk a little bit about what to do if you want to participate in a clinical trial. First of all, there are a lot of clinical trials going on, and you can find them at a website called clinicaltrials.gov. Every clinical trial that's going on that's been approved that has a permission slip or an informed consent will be found on clinicaltrials.gov. So the first thing you need to do is talk to your physician or talk to the specialist who's taking care of you. Talk about the possibility of participating in a clinical trial. But you also need to know and understand what's going on with you. And Mr. Scott, you really impressed me because you really are the best kind of patient that I could ever have. One that comes and tells me what they're going to do and what they're not going to do. And if I'm smart enough to listen, then we make a winning team. Okay? So that's really what you got to do to understand what your disease is. What is it? What type? What genes? What anything you can understand, you need to know. And you need to just, I say, write it down. I'm old school. Write it down. That way, when you get nervous, you can look at it. Okay? So once you understand that, then you can begin to look at possible clinical trials. And if you find a clinical trial that works, then learn more about it. Go to the informed consent, because it should tell you everything that's needed to know, everything that you need to know about that trial. And if it doesn't, move on. All right, now I'll say that again. If it doesn't tell you what you think you need to know, move on. Learn what you're going to have to do to make that clinical trial work. Where you're going to have to go. How much is it really going to cost you? Because the clinical trial is different from treatment. You've got your physician and the specialists who are caring for you, who are working with you in the clinical trial. So that's how you get into a clinical trial. All right? So now I've talked about the benefits. I've talked about what it is, talked about the benefits. It helps us move forward. So now, if they're so good, why don't we participate? You know, when you look at clinical trials, I think the previous speaker referenced that only about 5% of the people in clinical trials are African Americans. And we make up about 12, 14% of the population, but we don't participate in clinical trials. For the most part, much until recently, most of the people who participated in clinical trials were white men. Well, a lot of us say, well, I don't want people doing research on me. Let them continue. But that doesn't work, because what I eat is different. The way I live is different. And it is only through that kind of participation that we can be assured that the medicine works for us. That makes sense. Now, let's get down to the cold facts. There have been a lot of unethical things done around research in our society, and I can't stand up here and talk about it. As African American Black folks, we're skeptical, and rightfully so.
Right.
Rightfully so. All right? And if I put the real facts on the table, you know, there's a study that we often talk about, and I've called it a number of different things. It's called, the most recently I heard it called the U.S. Public Health Service Study about syphilis. Some of us know it as Tuskegee. But more importantly, most of us know that there were a lot of other kinds of research going on in Tuskegee that may or may not have been ethical, and people may or may not have known what was going on. Now, with the Tuskegee study, it was not a clinical trial. It was an observational study. Doesn't make it any better, because what happened in that study is they observed people with a disease or a condition, or it was really, in this case, a disease, an infection. And when treatment came available, the people who were running the study withheld treatment, which impacted the people in that study and the people they loved and cared about in terms of their families as well. But now, so Tuskegee wasn't really the only one. We can go back and look at a number of different studies that involved what I would call vulnerable people, right? People who, we don't even have to go even that further. We can even take a step back and just look at the life for us as African Americans through history. When it came to dividing up the resources, somehow we managed to get the short end of the stick. And when and the disadvantages, somehow we got a greater burden of the disadvantages. And that's the society that we live in. It has changed, but it is still very much the society that we live in. So why would you want to participate in a clinical trial? Why would you want to take that risk? Well, the thing I'm going to say is that since about the mid-1970s, there have been of efforts to protect all people in clinical trials. Remember, the first thing I said was safety. and effective, those are step 1 and step 2. I really call safety the most important thing. And then there have been a series of efforts to protect people who participate in clinical trials. I talked a little bit about something called the informed consent. Well, in order to have a clinical trial today, you have to have something called an institutional research branch, or an IRB, that really looks at the safety of that clinical trial. An institutional research board for every organization that's engaged in clinical trials. And they're there to make sure it's safe. If somebody asks you to be on an IRB, think about it once, think about it twice, and then say yes. Because they need community members. And your job, if you should be asked, because it's required, is to make sure everybody on that trial is safe and that the informed consent makes sense, it tells the truth, and it keeps people safe. It's the only way we're going to move forward. It's the only way we're going to move forward. And we really have to work together to make sure that all of these new medicines, because they cost a whole lot, work for us and do what needs. So I've talked about clinical trials, what, why, and how. Now I'm going to say one more thing. I talked a little bit around trust and mistrust, particularly mistrust in. And what I tried to lay out for you, that it's real. And even though I'd say for at least the last 20 years, most pharmaceuticals and most of us as physicians have done a whole lot of work to try to improve that trust. And what I would say, it's going to take more than that, because you can't take 400 years of history and try to change it in 20 years. And there's a delicate dance that continues to exist between the sons and daughters of slaves and the sons and daughters of slave owners. That dance still exists. And so we really have to advocate for ourselves in clinical trials. I keep going back to Mr. Scott, because he said, I determine who gets my access, and if you don't appear to be listening to me, I can go find somebody else. And that's the one point I'd want to say, or anything else. So as we move forward, we've got a couple things we got to do. We got to make sure that all of the safeguards are in place. And there's one more thing. If you look at clinical trials today, many of the researchers are still white. So we've got to grow our researchers and make sure that they're people who look like you and me, who are committed to doing this research, because I have a sneaking suspicion it might just be better in our interest. The second thing I say we need to do is, I talked about where the clinical trial is and where you got to go to get it done. I might offer that we might need to bring these clinical trials to the neighborhoods where people live. Now that would mean pharmaceutical companies and other researchers are going to have to rethink how they do things, but that's not so bad.
That's right.
That's not so bad. So we bring these clinical trials to the neighborhoods where people live, and we break down as many barriers as we can to people participating. Because in the end, it's about all of us working together to improve our health, to improve the treatments that we have when our health goes bad, and also to translate those improvements to the next generation. And that's what research is about, and that's what clinical trials are about. And so with that, there'll be some time to answer some questions, but I say as we move forward, we've got to think together how to keep the research, how to keep this whole engine working in our favor to keep us healthy and to make sure we get the health care that we need. Thank you very much.
As Dr. Sanders said, there will be an opportunity for some questions. But first, we're going to have our first panel, and we're going to have a discussion really on policy issues. I want to bring Mr. Howard Mosby back up, Dr. Martin, and Mr. Matt Lash. Please come on back up. Now, I'll give a little more introduction about these folks. Mr. Howard, step away. Oh, okay, he'll be back in a moment. Let me just explain.
Scott Stokes.
Well, so this,
Stood up. I
you
got it
have
wrong.
heard, you got it.
Got it wrong.
You've met Dr. Martin already. Matt Lash is the Director of Government Affairs for Artillex. In addition, also has some interest in mental health issues. It's kind of interesting. But we'll talk about that. Let's just begin the discussion. I want to talk about something called the kidney. The kidney pact. Howard, come on down, sir. We talked about Representative Mosby earlier. I should give you a little more information about him. He's a graduate of Georgia State University and a business administration degree, and he also attended the Management Academy at the University of North Carolina School of Public Health. It's pretty interesting. For several years, he was a representative from District 83 in Atlanta. And germane to our discussion here today, he was on the Health and Human Services Committee as well as the Ways and Means Committee. Mr. Lash, as I said before, is Director of Government Affairs, which means that he is, I don't use this in the pejorative sense, I guess a lobbyist. Or one who explains things to our representatives so that they would make the right decisions. Is that a better way of putting it? All right. And of course, Dr. Martin is one who provides care, and so she's also involved in the policy space. As I started to say, in this year in the legislative session in Washington, there was something called House Resolution 5074, also known as the Kidney Patient Act, was put forward. Mr. Lash, you have the microphone in your hand. Could you please explain to me what is the Kidney Patient Act? And why should we be interested in this?
Yeah. Wayne, thank you so much for that kind introduction. And just off script for a moment, if you'll allow me. I talked with the pastor on the way in. We had such a delightful conversation about my history. And I want you to know how meaningful it is for me to be here with all of you today as a Jewish American. I was taught from the day that I was born that our histories as vulnerable people have a lot in common and will forever be linked. So again, it is super meaningful to me as a human being, taking my professional hat off for a moment, to be here in this beautiful house of worship today. And thank you so much, Pastor and friends, for enabling me to be here. But as Wayne said, we've got a lot going on in DC right now. As my colleague Alan said as well, things tend to not move too quickly in Washington nowadays. But nevertheless, we have a bill. It's called the Kidney Patient Act, HR 5074. And as it's been said before, basically when you're on dialysis in this country, most folks are on Medicare. Medicare reimburses the dialysis facility a bundled amount. Congress has acted on 3 prior occasions to keep phosphate-lowering therapies like ours out of the bundle, because doing so or putting them into the bundle would decrease drastically access that all patients who suffer from this awful disease have to these life-saving treatments. This bill would, again, keep phosphate-lowering therapies out of that bundle. It's written for another 10 years. Likely that will be negotiated down from 10 years, but it's gone through 2 committees of jurisdiction. There's the Senate, and then there's the House. That's what makes up the US Congress, as most of you probably know. This bill was originally introduced in the House. It's now gone through both committees that oversee Medicare. The first one is House Ways and Means, and then after it was voted favorably out of Ways and Means, it went over to Energy and Commerce, where it was also voted out favorably. So this bill is destined to go to the full floor of the House of Representatives at some point to be voted on, but given the environment in Washington, D.C., we just don't know when that'll be. Best hope is for at some point this year, because as Alan said, if Congress doesn't act again, phosphate lowering therapies will go into the end-stage renal disease bundle as of January 1st. We're also in tandem working with our colleagues and friends as of patient advocates in this space with folks in the Senate to ensure that a companion bill is also introduced in the Senate. And then that's what usually happens once both bills are voted out of both chambers, then they come together and are reconciled and then hopefully at some point become law. So my plea to you today is to communicate the importance of this legislation to your delegation, particularly here in Michigan. And you know when you're sitting sometimes and you hear a statistic that just smacks you upside the head and you say to yourself, this can't be true? That happened to me when I was in Lansing a couple of weeks ago at a National Kidney Fund dinner. 1 out of 7 Michiganders has chronic kidney disease, over 1 million of you. 1 out of 7. And I heard that, and again, I was just like, man, that can't be true, but it is true. So I think that's what makes legislation like this all the more paramount to not only my livelihood, but also your lives. So again, if you could communicate the importance of that to your delegation here in Michigan, we need to get this bill moving because it's in the best interests of patients. So thank you. Hopefully,
Thanks, man. Howard, Mr. Mosby, would you explain, we've heard this term bundling quite a few times. We know what it means when we get our cable system, but it doesn't work. So what does bundling mean when we're talking about these medications and things for treatment of renal disease?
And thank you, Dr. Tuxer, for that question. Should have given it to this guy. No. So bundled payments. So you can think about it. I mean, you know about capitated payments. How about getting a combo meal at the restaurant? So we get the hamburger, we get the fries, we get the drink. So let's say you didn't want the fries, and nothing you can do about it because it's in there. And they price that meal based on what's in that bundle. In this particular case here, for chronic kidney disease or for end-stage renal disease, you have drug costs that are in there. You got laboratory costs that are in there. You have the cost of that facility that's in there, and capital requirements for that. And so all of these different things are in this bundled cost that Medicare is paying for this particular drug or this particular treatment. And what this particular program, what the Kidney Patient Act is trying to do is say, you don't need to put something else inside this bundle, because what's going to happen is at the end of this equation is the dialysis center. And they're the ones that are going to select what they're going to give you to meet what they think will meet your needs, when this product right here will do better for you, but they will take the cheapest option instead of giving you exactly something that will actually make your quality of life a lot higher and a lot better.
I will mention that if any of you have a question, please feel free to raise your hands and we'll get that. We'll come over to you in just a moment. But Mr. Mosby just said something rather interesting. It almost sounded like he said that the treatment center will choose the cheaper option, and I would infer from that statement that that may not be the best option. Is that always the case?
And many times that is the case. And it's quite unfortunate because when I first started as a nephrologist, we only had 2 options for phosphate binders. And sometimes that would go up to 8 pills with each meal for something like calcium acetate. Or it was a new pill came out, finally it was Renvela. And you would still have to take 4 to 6, which both of them had complications, bloating, constipation. And who wants to look at 6 pills before they eat and then throw them in while they're eating, and then it's going to affect their ability to enjoy the meal. And as we've gotten better binders out, as a physician, I'm like, oh, here, I want to give you this other pill. Guess what? One of these is going to be like taking 4 of those. So now you're going to only have to take 1 or 2 with each meal as opposed to 8. So I want to write for it. Remember we talked about those prior authorizations that sometimes doctors have to try to ask for? Well, sometimes it was like begging. And I had, when it goes through the dialysis center or through the insurance, nope, can't give it. No, but this will be better, and we're having non-compliance, and as we talked about, the phosphorus levels going up and it's getting worse. And I know that that means bad outcomes for my patient. It means that when those phosphorus levels go up, it binds with calcium and deposits in your blood vessels and hardens them and increases risk of calciphylaxis or coronary calcifications, vascular disease. So I'm begging them, and I can't get the medications because they're like, well, since we're bundled, that means I'm gonna have to take away from what I'm paying my staff. I'm gonna have to get rid of another staff member. I can't pay for this facility, or we're not gonna make as much money. So stay with the cheaper option, stay denied. And again, the Exposa, the amazing data on decreasing the reabsorption through the channels of the phosphorus in the GI tract, excellent medication. And I only have a few patients that have gotten approved, and we are fighting for it every day because again, we want our patients to live the best life they can. And again, if those medications are affecting their eating, it's affecting their protein levels, which can increase their risk of infections and bad outcomes.
We have a question over here. Please say.
So this is my grandmother, and I go to, and I hope she's okay with me talking. Is it okay?
Too late now. Hey, don't call her grandma. That young looking woman can't possibly. But go ahead.
This woman has 10 kids. So I take her to pretty much 90% of her doctor's appointments. And one of those is an endocrinologist and a nephrologist. And then I take her to her primary care physician, which used to be her cardiologist, but now he's her primary care because her previous one has retired. So most recently, they wanted to put her on Jardians, or the other one was Farxiga. Yes. So it's extremely expensive, like super duper expensive. And so her doctor was like, well, call the insurance company and see what they cover. So the medication that they said that they would cover is not even in the same class of either of those medications, and those medications don't have generic brands to them either. So we were in her primary care, also her cardiologist, and he gave her some samples, which was the good thing is, but at the same time, had she bought those medications at such an expensive rate and it didn't work, then she would have been out of just the start was like $500. So when you say that, as far as the pill would be a much less expensive route versus her having to do the dialysis, and probably a lot more healthier, especially for her age. It would be a lot harsher on the body. So how do you, or what would be the best route, or how do I approach this? Because at a point, she won't be able to possibly get any of the samples from the cardiologist. And it seems to be beneficial. She doesn't go back and see the doctor until June the 18th, I believe, when he just starts. So it'll be like, give or take 30 days or so. That's the part about it, is that the doctor, the nephrologist who recommended the medication, I'm sure he gets quite a few samples as well. He never even offered her a sample. But it was her cardiologist that I was talking to, and I was like, well, do you have samples or whatnot, where we can at least see if this is going to help her? Because the goal is to lower her blood pressure, which won't be so harsh on her kidneys. And overall, she's a very healthy person, but
Well, let us see if we can tease out some of the things. And thank you very much for bringing this up. And by the way, if you have trouble finding a physician that you need, I don't know, but I may know a nephrologist in the area to whom you may want to see. So let's take out, there are two issues I think that were just discussed. Number one was there was a cost of a medication. So if you talk about something now, what you're saying, so talk about getting you get the free sample. Sample don't last a day. So if we're talking about a medication that gets unbundled, that means the patient's now going to have to pick up the cost. Yes, you may have to let somebody go. Yes, you may get a lower payment, and yes, the dialysis center may get something low. but now she has to pick up the cost of the medication, and that may not be possible. And two, we heard the thing about quality of existence with others. I'll let each one of you tackle this in your respective ways.
So one, you basically have your own bundle in your household, right? And if she takes the time to spend all that money on the Farxiga or the Jardiance, then that means she's gonna have to take away from something else. You're gonna have to let go of the cable. That's what we're talking about when we're talking about the bundle in the dialysis unit. So in her case, yes, SGLT2 inhibitors, the sodium glucose transporter type 1, like the Farxiga, those and the Jardiance, those medications have been shown in non-diabetics to decrease their risks of chronic kidney disease progressing on, also decreases their fatal and non-fatal heart attacks, the development or hospitalizations for patients who have congestive heart failure. Awesome. In diabetics, it decreases about 30%. So it's an excellent medication. Those are the ones I said you should be begging your doctor for if you have chronic kidney disease. Just if you have chronic kidney disease, you should be on those medications in some way, shape, or form. So yes, so knowing that, why is the insurance giving us such a hard time in getting that medication? And yes, you have to have a nephrologist office in a primary care or cardiology. I love cardiology. I like sometimes when they take over for internal medicine, because at least they call me and say, get back to cardiology. We work hand in hand. We try to say the heart and the kidney are best friends. So cardiologist and nephrologist should be best friends. If I don't have samples, I'm calling my cardiologist friend like, oh, do you have samples? Because we usually share the same people, and we have each other on speed dial. So we make sure we're taking good care of our patients. And then our third speed dial is the patient. So, you know, it's a partnership, it's not a dictatorship, the way it used to be with the relationship with doctors and their patients. But to keep it shorter, it is not, and this is the sad part, when you said they told you to call the insurance company and try to get it covered. What are you gonna know to say to them? We have to say to them that this is needed, and you are with, I remember, I don't know if you know, Dr. Sanders may know Dr. Lonnie Joe. When certain medications first came out, he would call the insurance company and say, give me your name and number, because I want to be able to write down and go to court that you refused to give my patient what they needed to give. And they were like, okay, we're covering it, right? That's what we have to be doing, because we know the data is there. We want first SGLT2 inhibitors in the drinking water right now. I mean, we as nephrologists and cardiologists, because you're protecting the heart and the kidney by levels we've never seen before. When I say those are the medications, one of the medications that are coming out that may help us stop kidney disease, dialysis, from continuing to escalate, right? So that doctor has to be the one to call and say, we need the prior authorization. That doctor has to say, I say it's needed as a physician. My medical judgment is this is what's going to be best for them. And it may be something as simple as they wrote for Farxiga and there's a different brand that they would cover, that there's a deal with. And until then, I'm going to keep loading you with samples. There are assistant programs as well that these drug companies are providing to patients because they know that's what they need. And we talk about phase 4 trials. What he's saying is they're watching now that these are out so they can look at the bigger picture later. That's why they give us these samples, so that they can look at the data and say these patients are doing better on this medication to justify us trying to get it covered and for more patients to be able to have that availability.
Matt, could you comment about this? The CDAL is going to pick up the cost of this other.
Yeah. I mean, what this really comes down to at the end of the day is choice, right? And Mr. Stokes talked about it from a patient perspective, and by moving phosphate-lowering therapies into the bundle, you're effectively removing your ability as a patient to have choice. And you're also effectively removing your retail pharmacy and your trusted nephrologist from the equation. And then you'll be transported to a reality where the dialysis facility, which again is already constrained by a strained fixed cost that they are reimbursed for, is going to be making your medical decisions. And I hope that if that's what happens, that they will make the decision that's in the best interests of the patient. But we all know that when you're constrained by budgets and by economics, sometimes you tend to cut corners. So that's really our worry at the end of the day. And I guess the question that I would ask all of you, and what this really boils down to, is whether you'd have a bureaucrat in Washington, D.C. making your healthcare decisions, or if you'd rather have your doctor in science making your decisions. I know where I fall on that, and I suspect you're right with me, but that's really in a nutshell what this boils down to at the end of the day. And also what the doctor said as well about patient assistance programs. As a human being, one of the things that attracted me to Ardelyx is our patient assistance program. It's one of the most benevolent in the industry. And we've heard our CEO say on many occasions that health insurance or lack thereof should not keep a patient from accessing the life-saving therapies that they need. So we're very active on that front, ensuring that you all have access to the care. And we'll continue to do that regardless of what happens with the bundle. But I hope that answers to a certain extent the question.
In the course of your answer, Mr. Mosby, and I want you to comment. Being from Washington, I know a lot of bureaucrats and people. So I'm trying to decide, am I going to spend my health care dollar to take care of Pastor White, or am I going to cut back on some things and take care of the entire congregation? So where do you sit on this? And how do we, these are all good points. I mean, I don't know where, it is almost like the number of angels on the head of a pin discussion. So give us the final comment on this.
Well, I'll give my 2 cents. Give my 2 cents to Pastor White, but because that's all I have. No, actually, so all of this is policy. There is absolutely nothing that's going on in your life right now that's not affected by policy.
That's right.
I was having a talk with some kids in high school, and I was telling them about the policy-making process, and I was telling them that everything in life is affected by policy, and if you can think of something, tell me what that is. So one kid raised his hand and said, "What about sleep?" You know he's smart. Sleep. Really? I said, "You see that little mattress thing, pad thing, that tag on your mattress? What does it say? Take this off, you going to jail." And so he sat there dumbfounded, but it goes to show that we really do have to be a participant in this process. The question is there enough money in the system to take care of all of us? Okay.
Wait.
The comment was probably, but we're not yet.
And so the distribution of those resources is a function of whether or not we participate in the process.
Right.
And when you look at the Michigan legislature right now, Michigan has X number of seats in its House of Representatives. It has X number of citizens in the state. You divide the state citizens by the number of seats in that house, and that's how many people those folks represent. And that number changes every 10 years based on the census. And so we have to be participatory in all of these different things, in the census, and making sure we vote, and then making sure that we get out and do the other things, because voting is just a step. You don't change you start the process and change your community by voting, but you also have to stick your hands in the dirt and make sure that you're part of the process of making change happen. In this particular case around healthcare, because it is so complex, I know you asked for a long answer, but I'm going to give, I got the mic now. But, and you don't give a politician the mic and expect him to turn it back. When you're dealing with healthcare, first of all, people talk in acronyms. ESRD, what is that? So it's end-stage renal disease. Bundles. We say a lot of different things, but people don't, and so in our community, we sit there when the doctor's talking, we're like this. Because we're trying to get out of that. Because we don't know what the heck he just said. Am I going to die today or not? I'm not, okay, I'm out. And I'm going to ask somebody else, you went to the doctor, did he tell you about this? He said you was all right? Yeah, I'm all right. Well, I'm good too then. Because I don't need to ask no other questions, but you have to actually take control of your own health care. Mr. Stokes said it perfectly. I was not going to leave that office until I got my questions answered. And that's how you have to be in this process. And that's how the political process is. So, and I said a lot, sir, but I just want to make sure people understand.
We're going to come over that, but we're going to move on to our next panel, but I'm going to summarize what they just said with what Matt and Howard just said. For your best interest, get out and vote. Know what your condition is, and ask for what it is. And we're going to start another panel. They're going to be around at the end, but we've got to move on to our next panel. Because we have a rule that we can only have one member from Ardelyx on the panel at a time, Matt, you're gonna have to do tag team with Dr. Ryan. But again, everyone will be around after we finish things completely to answer more questions. So I want to bring up our next group of people. And we'll come back to Mr. Stokes in a few minutes. So we're gonna bring up Pastor White's gonna come up here. Matt, you get to go down. Alan, you get to come up. Larry, Dr. Sanders, you get to come on up. And Dr. Martin. Dr. Martin, you gotta stay.
Do I get to leave?
No, you gotta stay. You get double duty. Let's kind of shift things over to a bit more.
One of y'all get to
I thought it was kind of interesting we talk about policy and some policy things going on. But I want to start off with you, Dr. Martin. And you made a very strong point about us adding salt to our diet. But be honest with me. The amount of salt that I'm adding on by taking my shaker, is that really where the salt is that's in my diet? Or is it going to be what's in that can or what's in that preserved food that I'm getting? Is there more insidious salt that I'm taking in that I need to really watch out for?
Yes, and that's exactly why I need to add more. So we talk about clinical trials. So we were blessed to have a black physician in Detroit area that did a large trial of it's called the African American Studies in Kidney Disease, Dr. Jamerson, who was a close friend of mine. We actually participated in my private practice and patients. And it was teaching patients, black patients, how to pick better foods to assist their blood pressure. Because guess what they used to say about black patients? It is true. Our blood pressure is harder to control. They said, you'll never control it. So a lot of doctors have never tried to do any better. They're like, okay, we'll take these 1 or 2 pills, one with hydralazine, one with Lasix, one with 3. But we have better drugs. But they're like, oh, you'll never be able to control their blood pressure. So, but they never talked about diet. Nobody, except for me for long periods of time, want to talk about diet with the patient. That takes too long, they're not going to change. They didn't give us enough credit for that. The reason we have to be very careful with what we eat is not only when you stop adding the salt, you also have to watch what's inherently in salt. Back in the day, the reason we didn't suffer as much with kidney disease in the black community that we know of, at least, because they were watching these levels, but we go to Eastern Market, to the meat market, they kill the cow, take the food, the meat, and then they sell it to you and use it in 3 days, or else it'll go bad, it'll smell, right? Now you can see meat and steaks on the shelves for 2-3 weeks. Why is that? Because all those preservatives, it's just what the preservatives have. Not only do they have a ton of salt, they also have a lot of phosphorus. And phosphorus kills kidneys. Not only is it when you're on dialysis, it's also a part of one of the negative electrolytes that could cause kidney disease. So they inherently have that to preserve the foods. Canned vegetables, canned soups. I talk about all the time with my patients. I go into a list. So I was only have 10 minutes with my patients, I'll be there for a half an hour. Because we're talking about food. If their blood pressure is up, if they have salt in their legs, my first question, what did you have for dinner last night? I had a patient in the hospital swollen. I don't add salt to my food. Shoot, I barely even cook, but I don't add salt to my food. I said, well, what do you eat? Oh, I had McDonald's this day, I had Wendy's this day. But you know what, if you want me to let go of that, I'll go to a Chinese food restaurant. Everything high salt, right? But the canned vegetables, the box, the TV dinners, those frozen dinners, they're like, oh yeah, I'm eating, healthy, lean cuisine. It's preserved, tons of salt. So when I'm saying, if you actually don't add salt to your foods, and avoid high salt foods, you'll get to your goal of 2 grams a day. And there were studies in other countries where they went from 3,500, 2,500 millimoles of sodium, and they saw a 20 to 30% decrease. And they mandated it, their government, in heart disease, strokes. They didn't really have kidney failure because it wasn't in people with black. It was in other, European countries. But just mandating decreasing this salt that they're in the preservatives, in the foods, they made that impact. Why don't we do that? Some of those lobbyists, no, I'm saying. But there are people who are against that because they want to be able to preserve their foods. So that's why in this country, we're having the problems that we're having.
So Dr. Ryan, how do you tell a person to read a food label? One has to be a pharmacist to understand all those terms that are on the food label?
Well, today, I would say Google. I mean, come on. These
I don't have that much time to
right? Come on now. See, today you can look up YouTube, how to read a food label, right? At this point today, we don't have an excuse to be uninformed. I really believe at this point it's a matter of the heart that we, like the gentleman, the patient earlier spoke earlier, now I'm blanking on his name.
Mr. Stokes.
Mr. Stokes takes ownership, take ownership of our own well-being, right? And find out what is good, what is bad. Understand for yourself, right? What I need to make sure that is good for me is going into me, right? And then frankly, my healthcare provider is providing the health that I need. I've got a cousin who lives by himself. He's 72 years old in Los Angeles, who let's just say I'll use him health coach, and he'll call me from time to time, and it'll be basic stuff. But I'm like, ask your pharmacist. Lean forward and asking your healthcare professional. Don't have any fear or hesitation. With all due respect, you are paying them.
Yes.
Right.
So, yeah, so ask.
Notwithstanding what will occur at lunch, so we're going to take that off the table. But Pastor White, what do you tell the flock when they're bringing in the food?
Or what will you tell them now?
Go ahead, you pass the microphone.
Right. I think the question is, what will I tell them now? Because it is in our tradition to eat certain things, that we all enjoy, that has become a part of who we are. It's a part of our culture. But I think now we have to be more mindful of what we eat, and the fact, and Doc, you really raised a powerful point that I cannot shake to know that we have some teenagers that are on dialysis now that are dealing with many of these health challenges. But as you stated, when my diet consists of, McDonald's and Wendy's throughout the week, and I'm the first to say that there are times where I'm guilty, in going from this meeting to that meeting and always on the go, not making sure that I'm eating healthy and believing that you can eat the same way you ate when you were 18 or 19, thinking that was okay. The reality is, it is now, as they say, catching up with us, that we have to be mindful of our diet. So I think, and it's a challenge because those are the things that we enjoy. We have to be more mindful of our diet and make sure that, and doctors, you are correct me. I don't think that it's a major issue with eating some things that we enjoy, but eating it every day, it becomes a challenge. So we have to be more mindful of what we eat, and that's going to be my encouragement. I think other pastors that are in the room or that are viewing, that's going to be our focus, that we're more mindful of how we prepare the food and what food that we have when we have our gatherings.
We'll come to that question in a moment. I want to ask Dr. Sanders first. We heard a lot about phosphate and a few other things, but I'm kind of surprised I haven't heard anything about potassium. Is that a bigger worry for us when we have renal disease?
I think I'd prefer to touch Mark on that one.
No, you get this.
But yes, potassium is important. It's something that needs to be controlled, and it needs to be followed very carefully. But can I take, you gave me the mic, I want to pick up on something that you said. I think one of the things I think is in front of all of us is that we've got to figure out how to make soul food healthy food.
Right.
Okay. We've got to figure that out because the people who came before us figured how to take almost nothing
And make something.
Yeah. And so I think we have a responsibility to take it to the next level. And I think we can do that. So sorry for kind of
way to dance around that, Dr. Sanders. Listen, please take the question. We'll come back to it.
I just have a question in regards to the seasoning. You didn't provide a list, so could you just give us a short little overview of what would be good seasonings to add to the food outside of salt?
70, and I am all about, half my appointments are talking about what my patients are eating and what are their alternatives, right? So I tell people about Pinsies. I just did a health fair in Pontiac last year. We actually gave away these Pinsies spices that are salt-free. We have to know how to utilize our thyme, our marjoram, our cumin, our garlic. Garlic is actually good for you. Certain peppers. I make my greens sweet and spicy with cayenne pepper and agave. I don't use sugar. I use agave nectar, maybe even honey, those kind of things. But when you're talking about salt, all those other seasonings, a lot of things they do in the West Indies and a lot of things that we know about in Jamaica and different areas in Africa before it got Americanized or Westernized, Black people didn't have hypertension like they have here. It's only in the last 20 years that they've actually, or when they leave their country and come over here, in 10 years, it is actually in Asian patients as well. When they start eating the Western diet, they start to get obesity, diabetes 10 years, and their kids will start to act like ours and get these diseases a lot sooner because it's what we're eating and putting into it. Don't forget a lot of these meats have steroids, which is causing more of this diabetes, causing our 6-year-olds to have breasts. That's not cute, but when you're talking about spices, we have to start experimenting, getting online. When we talk about Google, even though it does take a little while, when I'm a patient, they said, oh, well, I had this and this better. I'm on Google. Nope, look at that, 600 sodium. I get on there to show them how they should look into what they're eating and if it's okay and what it's not. But you can look into a lot of salt-free spices and Google those. But that Pinsies, which is within here, they'll send it to you. And that, I think I've had a lot of people we've got a lot of good feedback. So Pinsies spices. But look for the salt-free, look for sodium, the sodium content on the back of the spice racks when you're looking for seasonings.
I see a challenge that is going to come in this church in which you're going to have luncheons where you're going to make a use creative substitution and have everyone taste to find out that you can maintain cultural and ethnic character and still have good and healthy foods. So there's a challenge for you. I'll tell you how we did it back in Louisville. Yes, ma'am, you have a question. Hold on a second, if you would, please. And if you'd stand up.
I do have a question, and maybe Dr. Martin and Dr. Sanders can answer it. Soul food has been around for years, and we're seeing health problems that people have, like our grandparents even, and great-grandparents have never seen before. Is it the soul food and the way we're preparing it, or is it the evolution of the meat and the other things that we're putting in it? Because again, like, this is stuff we've been eating for years, but our health is the worst it's ever been.
I'll take that. Here's what I'm going to say. Our health is the worst it's ever been. But now, rather than go outside, people are sitting playing their games.
Amen.
They're not exercising. They're not walking. You go back to our grandparents and earlier, although they ate the same food, but they were getting regular exercise because they had no choice. But I'm also going to say one more thing, is that life expectancy, when we go back to our grandparents and great-grandparents, was much shorter. And they didn't live quite as long. So I think that it's the lack of exercise, where we've moved to a more sedentary lifestyle, coupled with fatty foods. And I'm going to say one more thing. The other thing is that when our grandparents were around, there wasn't the plethora of processed foods. Even with canned foods, there just wasn't as many, and they weren't as processed. And anything that's processed, if it's gonna taste good, it's full of salt. Does that make sense?
Absolutely.
Okay.
And if you don't believe it, I want you to get a bag of potato chips that are unsalted versus salted, and see which one is eaten up first.
Doctor, if I could also add to that, I'm wondering, when my grandmother cooked greens, she went outside and got them from her garden.
You got it.
And when she cooked candy yams, she literally grew them. So I'm wondering, did that play a major part in it as well, because it was fresh that it hadn't been processed or anything like that, that made issues.
100%.
Yeah.
100%, 200%.
Yes.
It is the processed foods that I think we have to really be careful about. Anything that comes in a bag. Some people say if you shop around the periphery of the grocery store, it's much more healthy than going down the aisle.
And let's not,
And that goes back to healthcare disparities, because it's so hard to find those kind of stores in the metropolitan Detroit area and in the communities that are ours. And the gas prices. So it's very hard to get your rides to go to the ones that may have that. So that's by design, those healthcare disparities, which are non-medical entities that are affecting our healthcare.
what is the old adage? If the first three ingredients aren't food, don't buy it, right?
No, right, exactly.
We heard in the presentation that Dr. Martin did, Howard, she talked about people getting dialysis in the center and then peritoneal dialysis and home hemodialysis. Is that something that is economically feasible for everyone to get that in-home dialysis thing? Or how does that work out?
Well, I can speculate here. So the ESRD payment, the end-stage renal disease, I'm doing what I said that we should do. End-stage renal disease, Medicare pays 80% of the cost, and the patient pays for 20% of that cost. So when you go to these dialysis centers, that's what that exchange is. The home dialysis piece, so there is the cost of getting the equipment in your home, and then you actually being compliant with the process. So your electricity bill, making sure that you have the right supplies and resources in your home, could be a cheaper option long term on that 20% piece. And and if you can do home dialysis. Now everybody can't do home dialysis, but I'm being the pastor of the least qualified medical people up here. But I do know that in this particular case here, from a healthcare access and from a policymaker standpoint, where you get your health care, the closer it is to your home, the safer it is for you. The closer you get to that hospital, these facilities, the more dangerous that is for you.
So in actuality, it's cheaper to do home because one, you don't have the overhead. You don't have to, have the building. You don't have to pay the nurses. You don't. Patients actually do better a lot of times, so there's less medication costs. So they've actually had this big push towards nephrologists to actually send people home. I was doing that anyway. I send them transplant first, but if in that meantime they have to dialysis the PD, but the in-center, I actually had to do one of those Bonnie Joe moments. My dialysis unit deserves in-center dialysis. They're like, well, we are, in home dialysis. And I would not stop demanding it. And at that time I was on the medical advisory board for Fresenius from the regional and the national level. So only because of my power, my relationships, and my influence, because they actually tried to not reinstate my peritoneal dialysis that we were further down Jefferson. I said, no, my people deserve to have the opportunity to do peritoneal dialysis. And there's not very few in the Detroit area that are doing that. Same thing with home hemodialysis. Now we're up to, and it doesn't sound like much, but 5, but a lot of places only have 1 or 2 home hemo, or they had no options. Our PD clinic went up to about 20 at one point, where my partner has one that they have about 40, but it wasn't offered. And so a lot of times our patients, we, Black people, are offered that as if you'll never be able to do that. Sure. You're not that smart, or you can't be responsible. And it's very sad.
Now, I want to ask one other question. And while this is being answered, everyone's going to have to think about their final comments, which are going to be about 1 minute long. But the thing I want to talk about, perhaps this is going to be Dr. Martin, Dr. Sanders, and Will. You mentioned a change in the numbers for when we're looking at renal function. There's been some discussion recently about who gets transplanted and who is not, based upon a certain criteria of numbers. Could you tell us how that has impacted in the African American community, of why we're seeing fewer African Americans
whether or not the adjustments made by the United Organ, the sharing,
Opioids.
Network for Organ Sharing, whether or not that has impacted and made the field level.
Right. So I'd say probably about 15 years ago, they started looking at the estimated glomerular filtration rate, which is your percent kidney function. And the creatinine is based on muscle mass. So it's like, oh, well, blacks have more muscle mass. So your creatinine of 2, which would, maybe 50% in a white patient, they're like, oh, that's probably still like 60 or 60% because you have more muscle mass, you're gonna have a higher creatinine. And the problem was that a lot of the physicians, until it was blatant in your face that their creatinine was 6, they're like, oh, you have kidney disease, let me send you to a nephrologist. Or they would use that excuse and say, okay, they would misjudge the kidney function in black patients based on this evaluation, the criteria and the equation that we would use. So it wasn't until recent, and then because doctors were forgetting so much, they actually started putting it on lab work to put in their face. This is how much kidney function the patient has based on the calculations. Please decide on if they need to see a kidney doctor. And so then it started helping people get evaluated sooner, but again, because they had the black criteria or equation and number and the white number, there was a difference in when they'd be referred to, evaluations for chronic kidney disease and for transplant. And so if you can't get listed if you're less than 20, and based on the black equation, it's saying you're 25%, I may delay in sending you. And as your kidney function gets worse, it can go downhill pretty quickly. Sometimes you think you have 2 years and it'll be 2 months. And then all of a sudden your filters burn out. So it was delaying our referrals. The good news with some of the changes is that now they're going back for people who are on the kidney transplant list. And they're saying, hey, or they're getting evaluated. Well, back then, your actual kidney function went to less than 20%, actually 3 years ago. So we're gonna give you credit and give you those 3 years as when you should have been transplant listed on the transplant waiting list. So now those patients who were delayed in getting evaluated are actually getting that 3 years. And I told you it's 5 to 6 years in Michigan. Now may only be 2 to 3 years, and those are the benefits.
So you're trying to tell me that we finally get reparations, but it's coming in Dr. Sanders. Dr. Sanders, would you comment about this from your perspective there in the hospital? How do, there are various committees, and how have you seen this from organized medicine's perspective?
How do I see this from organized medicine's perspective?
Yes.
Well, I think first I'm going to draw on our own organization, the National Medical Association, because we really have to advocate not only for the practice of physicians, but we also really have to advocate for the health of the people that allow us the privilege of caring for them. And to me, that's why the National Medical Association and its branches are so important. Other than that, I think that it's really today, because medicine has become so specialized, that it's many of the specialty agent organizations that then will advocate for the very specific diseases, like the nephrologist, like the cardiologist. Those of us who are generalists have to recognize that and work together and really make sure that we are focused on the interest of our patients. And to me, that is the most important thing. And we need to remind each other.
I'd like to have closing comments. We're gonna start down this, and he always gets to be the last. It's his house, so Pastor always gets to be the last. Start with Dr. Ryan. Again, I want what you want us to take home from this as we think about it. And I'm gonna say one thing. Everyone's gonna start reading a label on your food thing. Okay, and like you said, if you don't know how to read it, you can Google it. But there's a YouTube video talking about how to read a food label. I promise you. You go ahead, sir.
So I would start with making sure that your voice is heard in your doctor's office and wherever you go. And along with that, make sure your voice is heard with the policymakers. I know that the healcollaborative will have some action items, some thoughts on what you as individuals can do, or maybe if you're a part of a group, can do to make sure your voice is heard. But please understand that having your voice heard is key to having action taken and policies created that help make sure that we have what we need. At the end of the day, like I'll just keep repeating, silence is agreement. And whoever they hear from, you've heard the saying, the squeaky wheel gets the oil. Right. Yes? So if you're not squeaking, then just understand that means you're saying it's okay to pass me by, right? So we are hopeful that people will raise their voice to support the Kidney Patient Act.
That came from a Howard man, so it's a black fact. Go ahead.
All right. First of all, I'd like to thank you, Pastor. Thank our delegates for allowing us the opportunity to actually bring this information to you all. One quick thing about the transplant piece before I get to my understand now, look at the balance in our community. And it's generally young people that are dying. And these young folks have great organs. I just want y'all to think about this. But we're not on these transplant lists. So if you think about this from a country standpoint, we export a lot of stuff, but we don't import. So, and all of this is actually policy-wise. So really, my takeaway is make sure you get actively involved in the political process. I don't care who you vote for, personally. Well, I do care. Let me back that up. I care.
Especially
However,
now.
I do care more that you actually participate in the process and then be active in your community to make sure that change that you want to see, you're there to make it happen. And so and we're here to help our delegates. They're pushing this big bill here, but we just want to make sure that our community is informed and that you all get engaged. So thank you.
Thank you.
The first thing I would say is don't let research and the idea of clinical trials scare you, but do be careful and pay attention and make sure that the clinical trial or whatever research you're engaged in is in your interest and the people you care about.
I've given you a lot of information, so I'll try to keep it brief to my 1 minute. You are what you eat. Be careful of what you eat. Talk to your doctor, know your numbers, especially the blood pressure numbers, because even if you have good control of your diabetes, but you don't have control of your blood pressure, it will expedite the diabetic kidney disease and cause damage and dialysis. Make sure you have doctors that are listening to you, are in your corner, and will get you by hell or high water. Can I say that here? What you need. And if you don't, find another one. Make sure you have an advocate who comes with you to your appointments, because sometimes you'll give a lot of information like I gave today. It's like, what did she say again? Or men who go back home and again, why I say, so what did your doctor say? I'm good. I have wives' numbers on speed dial on my phone, like, let me just tell you. Or I call them, what did you feed your husband yesterday because his blood pressure's high, you're trying to kill him. Glad to educate the family. Bring your kids and make sure you have a doctor that's also teaching your kids what they're supposed to eat. What we need to do in the Black community, how to be positive, but there also should be their mentors, because we need Black doctors. And lastly, I would say, make sure you know who your politicians are that you're voting for. Whitmer actually started a health disparities task force, because I had a lot of my friends that were in it, and are a part of it during COVID. We need people who are going to make changes in our community so we can lessen these social determinants of healthcare. So no, we raise our voice to demand grocery stores, parks, clean air, our access to healthcare, insurance changes, and get away from these restrictions.
Before the pastor speaks, I will remind you, please fill out the post-survey. If you haven't filled out the pre-survey, you can do that now too. Fill out the post-survey, and let me remind you, as I did last week, the only thing standing between us and lunch is him. Pastor. And thank you again. Thank you. I apologize. Let's give a hand to our panel. And by extension to our policy panel, which included Mr. Lash. Thank you very much. And thank you all for being here with us. Pastor Wayne.
I knew he was going to set me up like that again. He did the same thing last week. The main thing I want to encourage all here today and those who are viewing, become your greatest advocate ask questions. And as the doctors were speaking, I was just thinking, even with my own experience, sometimes when we listen to doctors, we almost make them bigger than God and believe that whatever they say is absolutely correct. We can't ask questions. If they tell us to take this, we take this without asking any questions and getting a better understanding. And the one thing that I've learned today is we've got to ask questions, and we have to make sure that we're comfortable. And if we're not comfortable, keep asking those questions. And if you don't get the answers you're looking for, feel free to go and find someone else, because again, you are compensating these people that are supposed to be giving you the best care possible. And so I think that's something very key. And I think someone already stated this, that if you need to, take someone with you to the doctor to make sure that you're not missing the information. I think that's a major key in our communities. We get so overwhelmed that we shut down and don't continue to do the research to make sure that we're getting the best health care possible. And also to our brothers who are here, we have to encourage others, especially our black men, to make sure that we're getting those physicals and that we are properly taking care of ourselves as we should, because the Lord wants us to live long and healthy lives, but we've got to do our part. Amen. To make sure that we are taking care of ourselves, that we can have a high quality of health. So again, thank God for you all who are here. And can we give all of our health professionals and all those who have come here today, give them a great hand. We appreciate them so much for being here today. And I must say this, let us continue to keep the Obama family lifted up in our prayers, as I believe within our community, he certainly should go down in history as being one of the greatest presidents that we have ever had. Amen. When we see what has happened over these past 8 years with not President Biden, but number 45, you all know who I'm talking about. When we see the things that are happening and the things that have happened during his administration, and we put it up against the administration of Barack Obama, all of us in this room know if half of the things that he has been accused of, not prosecuted for, half the things he or tried for, if that would have happened with President Obama, we would not have even called him a president. He would have been impeached and removed. But he served, amen, and we need to remember this, he served with an impeccable record, with absolutely no scandals whatsoever. And we have to appreciate that. But again, let us continue to keep his family in our prayers, that God will continue to comfort them, and the Lord will continue to comfort past First Lady Michelle Obama and give her strength, because there is nothing like losing a mother. And so we want to keep her in our prayers, because even as high as her family has gone, death yet still invades all of our ranks. And so let us continue to keep them in our prayers. But again, thank God for you all who are here. Let us make sure that we take this information, that we share it. I'm gonna need you all to help me, because you all lifted Trustee Stokes up real high today. I got to make sure, amen. Brother Stokes, we're gonna start saying whatever Stokes said, that's what you tell your doctor when you go there, you do that. But I want to appreciate you for sharing your testimony, because I know so many have been empowered by what you have shared today. And thank God for Sister Tara on last week, who shared with us her testimony. And we don't have to live in a place where we feel we cannot advocate for ourselves. We have to stand up and ask questions and know that we matter and our community matters. Amen? All right, well, at this time, I believe we can pray. Are we done? All right, very good. All right, well, let us pray. Father God, we come right now. Again, we thank you, Lord, for this day. We thank you for all that have taken place. We thank you, Lord, for all of this phenomenal information that we have been presented with. We thank you, oh God, for those who came out today. Now, God, help us that we may take the information that have been presented to us by our Alexa Heal Collaborative and all the health professionals that have been here today that have presented, oh God, that we would take it and share it, that we would take it, that we may empower our family members and our friends, oh God, that we can live productive lives and live well lives, oh God, that we may be able to do your will. We ask you to continue to bless us, oh God, that you would bless the food that it have been prepared for the nourishment of our bodies. Help us that we be mindful of our salt intake, and we ask that you would keep us in your care. It is in Jesus' name we pray. Amen. Amen. All right. Praise God for you. Listen, we can continue this conversation, this dialogue over in the William R. Haney Center. All right, we need about 10 minutes, and once we leave here, we'll be prepared for us to all have lunch over in our William R. Haney Center. God bless you. Thank you so much to those of Dexter who were here today. Thank you.